uh, their CVs and their history as to what brought them here. Jake is the director of the Traffic Safety and Research for AAA in Washington, D.C. We would like to thank AAA and NHTSA for making this summit possible today and bringing everyone to this room so that we can engage in this discussion and come out with more knowledge in what we walked in with and more enthusiasm than what we walked in with, so that we can meld the two together and come out and work to find effective ways to deal with this issue. Jake brings with him a national perspective of drug and traffic safety issues from both an academic's perspective and from an actual boots on the ground situation. We're very fortunate to have Jake here, and thank you for coming, Jake. Please welcome Jake.
Good morning, everyone. Is there a clicker for the slides, or will you be progressing them for me? Come grab that from you. So, Colonel, I would just like to echo a point that you made, which was you talked a little bit about prevention. And I'm a public health guy. Before I came to AAA, I managed a state-certified health department in the Chicago area. And I worked on everything from childhood obesity prevention to substance abuse and whatnot. And certainly while we work to manage this issue and dampen the growth of the problem, preventing it is extremely important and needs to be done concurrently with the work that we're doing to reduce it. So while we're getting the slides up and running here, one of the things I want to talk about is to remind everyone in the room that just to manage expectations. We're not going to solve this problem here today, but one of the things that we can hope to do is to move forward having an idea of where we will start to focus our attention, which pieces of the puzzle will we start to really rally around that will lead to solving this problem moving forward. One of the things I was asked to do today was to set the stage for the group. We have a lot of very passionate speakers who are going to talk to us today. We're going to learn a lot. Very little time to break and to chit-chat, but this is a good thing because we could talk for a full week about a variety of sort of angles to the drug driving problem. We're all familiar with the overall number of highway deaths in the United States and how they've trended down over the last decade or so. But even with all the progress that we've made, still roughly every 16 minutes somebody dies in a traffic crash. This is something that you all know very well. When we usually talk about impaired driving, we think alcohol. And that's for good reason. Roughly a third of all impaired driving deaths involve an alcohol-impaired driver. And we've made a lot of progress in this regard. But in terms of setting the stage on drug driving, we need to recognize that this is a major public health problem. And you've heard a little bit about this already today. Historically, it's an issue that's been ignored, although I'd say for the last decade or so, stakeholders like the folks at NHTSA and some of the other federal agencies have been paying attention to this issue and have been trying to do a lot to learn more and understand it better. We still have a lot of learning to do, and you'll hear about that a little bit from some of the folks that we'll hear from later this afternoon. In terms of sort of the national scope of the drug driving problem, probably the best data that we have to really understand the extent to which people are driving while impaired by drugs is from NHTSA roadside survey. And just, high-level results here, just looking at results from the oral test at the roadside, we know that nighttime drivers are test drug positive more frequently than daytime drivers. And when you look at blood and oral test results at the roadside, we know that roughly 16% of nighttime drivers test drug positive at any given time. Most common drug found in the system is they're listed here, but marijuana is the major culprit. Probably the biggest danger, and one of the things I hope I leave you with today, is that to consider alcohol and drugs a zero-sum game would be a huge mistake. And so this is a drug-to-driving summit, true, but really we should be talking about substance-impaired driving. And while we've made a lot of effort and progress in addressing the alcohol-impaired driving problem in the United States and certainly here in Vermont, we know that a lot of folks who are found impaired by alcohol also have drugs on board and vice versa. So we really need to address these problems together. If we're going to focus on drug-impaired driving, we need to do so in the context of alcohol-impaired driving. We shouldn't treat them separately in silos. So drugged driving, it's very complicated. And so one of the things I'm going to try to do here in the time that I have this morning is to maybe organize the information just a little bit for us as we start to dive in to the details later this afternoon. So when we're talking about prescription drugs, the problem really is when folks who have no prescription are using them, or when folks who have the prescription are using them incorrectly, which means too little, too much, not following the scheduling of their doses, or using them with alcohol or other drugs that magnify the impact or the effects of the drug. And a caution I would like to share with all of you is the fact that there are a lot of people who take drugs as prescribed. They're doing what the doctor told them, and we certainly don't want to scare them from taking drugs that they need to treat or manage a health condition that they have. One of the ways that AAA has tried to address this problem is through a free tool that we've developed for everyone to use. You don't have to be a member. It's called Roadwise RX. And what this does is it allows you to go in, it's online, to list or select from a series of drop-down menus all the medications that you take, prescriptive, over-the-counter, otherwise, and submit that information. What it will do for you is produce a report that summarizes all the medications that you take, the side effects of those medications in terms of driving, and also flag any potential interactions between the medications that you're taking or any foods that you consume or alcohol that could affect your driving as well. And the call to action here is to take this printout to your doctor or to your local pharmacist and to review the results. It's sort of like a virtual brown bag. And so do we have any healthcare professionals in the room? So you've all heard of the term brown bagging before. So that's really what this is. And so the idea here isn't to scare people from taking the medications that they need. It's to provide them with the information and get them talking to the right people so that they can find out how they can adjust the medications that they're taking, the dosage, the timing, those types of things to help mitigate the risks of driver safety as it relates to the medications that they need to take. One thing I'd like to flag for you is, and to recommend, is to focus on high-risk groups. And so if we look at older drivers in the United States, we know how rapidly that age group is increasing here. From some research that the AAA Foundation did in 2008, we learned a couple really interesting facts. First, we know about 8 out of 10 drivers over the age of 65 take prescription medications on a regular basis, and that about 69% of them take one or more potentially impairing medications. These are prescription drugs. They're doing what their doctor told them to do. And of course, this makes sense because as we age and we start to deal with more chronic diseases and medical conditions, we take more prescriptive medications to manage and treat those conditions. So this isn't surprising. What is surprising is that roughly half of these people have never had a conversation with their healthcare provider about the risks that the medications they take could have on their driver safety. So something to focus on. And clearly there's a huge opportunity here for all of us in the room and in the state of Vermont to work more closely with the medical community to help get them to educate and provide information to their patients about how the medications they take could affect their driving. Of course, medications come with an insert that usually flag this information, but if you think about your average person who's 65 and older and how tiny that font is on that insert, and whether or not any of us even read that insert, it sort of underscores the need for those conversations to be had rather than just the insert to be given. So moving over to abuse and addiction. When I was in the health department in Chicago, I mentioned that substance abuse was a huge problem in that community, one that the health department tried to address. One of the things that we learned, one of the trends that we saw is something called sprinkle parties. And this was a phenomenon in the Chicago area, primarily among young people. And so what people were doing is showing up to parties and throwing into a bowl in the center of a table in the kitchen or dining room any pills that they could find in their mom or grandmother or aunt's purse or in the medicine cabinet at home. And so you'd have sort of a rainbow of pills or medications in this bowl, and then kids would just take a handful and see what happens. So this has become quite popular, and the media likes to pick up on this. And so, when we talk about prescription drug abuse, a lot of people think of sort of the route to obtaining these medications is from medicine cabinets and friends and family. And in some cases that's true, but in the work that we did in Chicago, we learned that most of the folks who participate in or who obtain drugs in this way use those medications less than 10 times in the previous year. So if you're addicted to a medication, this route of obtaining the medication is not enough. It is not sustainable for your addiction problem. So these people are getting it in other ways. And it underscores the importance of intervention and treatment. We've heard a little bit about that today already. And obviously there's a huge opportunity here for law enforcement and healthcare professionals to identify and refer the people who would benefit the most from treatment. Want to just give a special example here, and we've heard a lot about heroin, but just to give you some context, let's talk about opiate painkillers here. These are your hydrocodones, your morphine, et cetera. A single daily dose prescribed to an ordinary patient who's taking this medication to manage chronic pain, for example, is going to get about $100 on the street for one pill or one dose, and it can kill a non-user. And people take this and get behind the wheel of a car and drive. We don't know how common this is because the data aren't quite there yet, but this happens. And so this is just one example of dozens and dozens of medications that are potentially impairing that we need to address when thinking about the drug driving problem. This has become such a problem in the US that the CDC has declared it an epidemic here. So if you thought medication or prescription medications were complicated, marijuana and driving is a hot mess. There are debates about sort of the way that people respond to marijuana, if they're recreational versus medicinal users, if they're chronic versus occasional users. This, of course, complicates the presence versus impairment argument and drug per se laws where they exist across the states. People don't agree on the duration of impairment, despite what the published literature says. There's still this lack of agreement. Obviously, the concentration of THC, the active ingredient in marijuana, has changed dramatically over the last few decades. And then, of course, there's marijuana laced with other substances, things that we don't even know much about. And I know Joanne will talk a little bit about this later. And I had already mentioned the drug per se limit here. Bottom line, we have many more questions about this issue than we do answers. Yet we see a trend in legalization either for medicinal or recreational use across the country. It's getting a lot of media attention. And so there's a lot more focus on this problem. One of the things that we're doing at AAA through our foundation is some new research. We just voted to approve this research earlier in the year. About 18 months from now, we're going to have the results of the first study there in Washington State, and about a year from now, we'll have the results of the second one. Altogether, the bottom line here is we're going to answer these questions. We're going to know a lot more about sort of how the legalization of marijuana in Washington State, for example, has affected the incidence of cannabis-involved driving. We're going to know a lot more about the relationship between the presence, the blood concentration of THC, and crash severity. And we'll also learn a lot more about what a realistic threshold, if there is one, for THC is in blood, and at which impairment and to what extent crash risk has increased for folks involved in these types of crashes. This will be really helpful. In Washington State and in Colorado, there's a per se limit of 5 nanograms per deciliter of blood. And this really isn't based on any scientific research evidence. It's completely arbitrary. And depending on the forensic toxicologist that you speak to, they'll say it should be lower. Some will say we don't know if it should be lower or higher or if there should even be one. So the results of this work will be really important. And I know that Mike Brown will talk a little bit about some of the work that is being done over at NHTSA as well that will help answer some of the many questions that we have about marijuana impaired driving. So in terms of public policy, I'm not putting these or listing them on the screen to advocate for them necessarily, but they're things that I've heard talked about. And so I just put them here for you to react to. I've heard some folks say, look, there's roughly 1.2 million arrests made for alcohol impaired driving a year. Why shouldn't there at least be the same number of tests done for drugs in those same people? Well, obviously there's cost implications, training time, the capacity of labs to manage these tests. So these are real world problems, but an interesting policy to consider. Drug per se statutes and DUID laws. And what complicates this is the presence versus impairment issue. it's one thing when we're talking about illicit drugs or illegal drugs, but when we start to legalize some of those like marijuana, things get very complicated and it becomes much more difficult to prosecute these cases. You'll hear more about that as well. All of you, I think, are pretty familiar with DEC programs and sort of the DREs in your state and the benefits that they offer. But there are only so many of those to go around, and there are many more drivers than there are DREs. And so that's when ARAD comes into play. You'll hear more about that later today as well. An interesting recommendation that I've heard just recently is sort of to consider the standard that we have for commercial drivers, for alcohol and also for drug. I think for alcohol it's 0.04, and for drugs it's 0 tolerance. So obviously these are people who are transporting others, and so it makes sense that they might face these types of standards. But you know, we all drive on the roads too, and the extent to which we drive safely affects other road users as well, innocent people who are following the rules and obeying laws and whatnot. And I've heard a lot of talk recently about holding all motorists to the same standards that we might commercial drivers. So again, not advocating for any of these policies, just listing them here because I've heard them talked about a lot recently. So I just leave that there for food for thought. So I was pretty vocal earlier about making sure that when we talk about the drug driving problem and seek to manage it, that we don't do so in a vacuum, and that we do it in the context of alcohol impaired driving as well. And so one of the things that I want to talk about are ignition interlock programs. And I'm going to be pretty brief here, but AAA last year came out with a series of legislative guidelines for states to consider when looking to strengthen their alcohol ignition interlock programs. I'm just going to run through them very quickly and then summarize, and I think we have a break. So here's a map of sort of the current state of play when it comes to alcohol ignition interlocks here. You can see the reddish states are where there are required or highly incentivized all-offender alcohol ignition interlock programs. And all the blue states are for mainly high BAC repeat offenders. So in terms of the recommendations that we make at AAA for these programs, obviously we think that they should be mandatory for all convicted drunk drivers, even those convicted for a first offense. Also, we think that these programs are best managed jointly through the courts and administratively. And the balance there depends on the state. There is no one-size-fits-all way to do this, but certainly we think that there are benefits to having both groups involved in the management of the logistics for these programs. We believe strongly in performance-based removal of the device, and also think that the courts should be leveraged to impose graduated sanctions for tampering or altering ignition interlock devices or otherwise attempting to circumvent the law as it relates to these programs. Almost wrapped up here, we think that alcohol ignition interlock programs or alcohol ignition interlock should be made available to all offenders as soon as possible, and this is primarily due to the fact that drunk drivers will learn that they can drive on a suspended license rather quickly with little risk of being identified by law enforcement. And so the faster that we can get the interlock on the car, the faster we can separate drinking from driving. So I've heard some people react to this recommendation as, well, isn't it kind of being easy on convicted drunk drivers? Well, that's one way to look at it. Another way to look at it is if what we care about is prevention, then we need to separate the drinking from the driving. And this is a way to do that while still letting these convicted offenders be productive members of society. Let them go to work, let them go to church, let them do the activities of daily living, but without any risk of them driving vehicles equipped with an alcohol ignition interlock. We also think that these programs are expensive, and we believe strongly that the costs associated with them should be borne primarily by the offenders. And there are unaffordability funds that many states with alcohol ignition interlock programs have set up with pretty strict requirements for folks to tap into those funds if they say that they can't afford to pay for the program. And then final recommendation here is we think that it's really important to combine treatment with alcohol ignition interlock programs. In particular, I think that if we can provide alcohol ignition interlock fails or the data associated or produced by alcohol ignition interlock devices to substance abuse and treatment providers, that helps them tailor and magnify the impact of the treatment that they offer to people, because it helps them understand sort of when they're attempting to drive drunk, what the triggers were for them to get behind the wheel after having consumed alcohol, and might help make the treatment provided a little bit more effective. So in summary, if you remember nothing else that I talked about this morning, I want you to remember these three things. Number one, treat alcohol and drug-impaired driving together. Don't address them in a vacuum separately. Avoid knee-jerk policy making. We have more questions than answers, but the good news is that we're doing the research to help answer some of these questions. And also to recognize that there's low-hanging fruit for us, and to consider high-risk groups in that regard. So think alcohol ignition interlock devices or programs, meds in older drivers, and expanding DRE and A-RIDE programs. So that's where I'll wrap up. If anyone has questions, I'm happy to answer them. Otherwise, I think we have a break.